Welcome to our live webcast. Ouch, my foot hurts. Top 5 painful foot and ankle conditions for the primary care practitioner. Thank you for joining us. My name is Jacob, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. Closed captioning is available at the bottom of your screen. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief CME evaluation summary form. Please take a moment to complete this survey in order to receive credit for attending the webinar and providing feedback of the webinar. We are joined today by our speaker, Dr. Christopher Hubbard. At this time, I would like to turn the microphone over to Dr. Hubbard.
Thank you, Jacob. So excited about joining Atlantic Health System. I started here a couple of months ago after being in New York City for the last 20 years, and everybody's been great. And I'm excited, happy about being able to give this webinar tonight. So to get started, I expanded it a little bit in terms of going past just the top five, just to sort of give a broader spectrum in terms of some of the foot and ankle conditions that we'll see. So just briefly to sort of go over some of the anatomy of the foot and ankle, and we'll get into some of this a little more detail with the specific condition. But the basic anatomy or bones of the ankle and the foot include the tibia, the fibula. You have the medial malleolus, which is the inner part of the tibia, the lateral malleolus, which is the outer part of the fibula. In terms of the different ligaments of the ankle, the major ones that we'll talk about are the anterior talofibula as well as the calcaneal fibula. We see those in the lateral ankle sprains. The deltoid ligament, which is the medial ankle sprain, and then the syndesmotic or the high ankle sprain, which is the anterior tibiofibular ligament. Some of the other bones that we'll discuss in terms of injury include the calcaneus, the talus, the metatarsals, and the toes. So broadly, in terms of the different types of conditions that we see in the foot and ankle, can be a problem with tendons, the ligaments, bones, or joints. In terms of the tendons, tendons are muscles that then with the tendon connect to the bone, crossing a specific joint, allowing motion at that joint. Some of the conditions we'll see is just an inflammation or a tendinitis, a tear, typically a partial tear, a longitudinal tear, and sometimes even complete ruptures. In terms of the ligaments, ligaments connect bone to bone, stabilize different joints of the ankle and the foot. So again, we'll see partial tears or sprains, as well as complete disruptions of the ligaments. Talk a little more about the anatomy of the bones of the foot. Essentially 26 bones of the foot, 2 phalanges of the big toe, 3 of the lesser toes, 5 metatarsals, the medial cuneiform, middle cuneiform, lateral cuneiform, the cuboid, calcaneus, the talus, and then the tibia and the fibula of the ankle. In terms of the bones, essentially we're talking about fractures, either acute or stress-related type. In terms of the joints, typically a loss of cartilage and arthritis or arthritic condition of the joint. That almost always in the foot and ankle is a osteoarthritis, which is a traumatic or post-traumatic arthritis. Lesser an inflammatory type condition, which typically can be a rheumatoid gout or psoriasis. Occasionally we'll see a septic or a infectious arthritis as well. In terms of just the history of any sort of foot and ankle problem, essentially is an acute specific twist or turn, or is it a more chronic condition? If it's chronic, then trying to elicit was there any change in activity, any change in shoe wear or exercise, what sort of precipitated pain. The exam, typically if the patient can, we want to get a good exam with them placing weight on the foot. We want to see both sides, so using the contralateral side as a good example or comparison. We're looking for alignment in terms of the foot and the ankle. It can be easier to see an area of swelling or bruising, specifically one side versus the other. In this case, this patient has we call a cavus foot, a high arched foot, really on both sides. In terms of exam, we want to measure their range of motion. Active is the patient using their own power and strength to try and move that joint, whereas passive is you're using your hands in terms of trying to assess the flexibility of the joint. X-rays, similar if we can, we want to try and have the patient bear some weight. That looks again at alignment. It looks at the joint space, so we can see that narrowing of the joint space in an arthritic condition that we might not be able to see in a non-weight bearing view. And again, in terms of contralateral view, that can be helpful in some deformities to compare to the other side. There are types of stress views that we can do as well that can elicit any laxity of a joint or any increased motion or instability that we might not see just with a passive type of X-ray. In terms of going into some of the ligament and tendon disorders then specifically, one of the major injuries is the ankle sprain. So really there's two types: the inversion of the foot, where the foot turns over. That's a typical lateral ankle sprain, very common. The opposite is really this eversion of the foot turns out. That's what we call a high ankle sprain or syndesmotic sprain. So in terms of the lateral ankle sprain, typically it's this bruising, ecchymosis, swelling laterally along the ankle. Typically what's being injured is this anterior talofibular ligament, this calcaneal fibular ligament, so those can be partially torn or sprained, can be completely disrupted or torn, so it can be certainly a spectrum of these types of injuries. Typically we put these patients in some sort of brace or boot initially. For the more severe sprains, we like to see them back in a couple weeks, assess, and sometimes some physical therapy can be helpful. Occasionally, if both ligaments are torn, then one can have an instability or laxity of the ankle, which can lead to repetitive sprains and other problems. So, the high ankle sprain is this ligament. So that's or these ligaments. These are the anterior tibiofibular ligament. So that's the anterior. There's one in the back, the posterior, and then in between the two bones, the tibia and the fibula, that's the interosseous ligament. So really three ligaments of what we call the syndesmosis. Those ligaments connect the tibia to the fibula at this level. So again, that's an external injury where the foot turns out. And this can be a sprain where it's torn or partially torn, but there's no separation or diastasis, or there can be a separation of that space. In those cases, that needs to be surgically stabilized. This actually might be a little blurry, but this space is a little widened. This space is a little widened. When you see that without a fracture at the ankle, one thing to be aware of is there any tenderness or any discomfort higher up along the leg? This Mason-New fracture or injury is when we see this fracture of the proximal fibula along with this syndesmotic injury where there's separation or diastasis at the ankle. So that's one thing to keep in mind. In terms of the tendons of the ankle, the four major that we're going to talk about are really the Achilles, Peroneal Tendons, the Posterior Tibial Tendon, and the Anterior Tibial Tendon. In terms of the Achilles tendon, typically the types of things we see are rupture, so that's a complete disruption of the tendon above its insertion site. A tendinosis implies really a thickening of the tendon, a partial tear of the tendon. These typically are more at the insertion of the Achilles as opposed to the non-insertional tendinosis. Briefly, in terms of the anatomy of the Achilles, really it's formed by three muscles: the medial and lateral gastrocnemius, and the soleus, which then form the Achilles tendon, which then attaches to the back of the heel. There is a decreased blood supply area about 2 to 6 centimeters from insertion site, which does leave the tendon vulnerable and is the most common area where the tendon is ruptured. In terms of the ruptures, typically this is the age group of 30 to 50, more males than females, sort of the weekend warrior in terms of the frequency of their athletics. There is a familial occurrence to it, and there is one study that has looked at that if one ruptures one side and then returns to the same level of activity in sports, that they have a 26% chance of rupturing the other side. So that's something to make the patient aware of. Usually these patients don't have any symptoms beforehand, as opposed to the tendinosis of the Achilles. And in terms of the mechanism, usually this is with the knee straight and the patient pushes off in terms of the foot. They'll feel like they got kicked in the back of the calf or the Achilles, and then they turn around and no one's there. So common in basketball, volleyball, tennis type sports. The diagnosis is usually pretty straightforward. Usually a palpable gap in the back of the Achilles, but in terms of the exam, if you sort of walk your way down from its attachment at the heel, and you can feel the tendon, and then you sort of feel the gap. So that's pretty usually apparent early on after rupture. This Thompson test, which is squeezing the calf and trying to elicit some plantar flexion of the foot. So in this case, this would be a negative Thompson test, in that there's some continuity of the tendon and the foot bends down. In this case, there's no continuity, so the foot does not bend. So the best way to do this is the patient prone. But that's just another test. You can try to have them single heel rise as well on that side, but usually pretty sore and pretty weak to be able to do that. Intraoperatively, and almost all of these do need surgical repair. Really, it's just a mop-end appearance in terms of what it looks like. Different technical ways in terms of how we bring the two edges together, but typically, again, surgery in terms of fixing those. The insertional tendinopathy, this is really the pump bump. This is sort of the enlargement of the back of the heel. Patients will feel pain, discomfort in a closed shoe. They'll be pretty sore on both sides of the back of the heel. They'll feel pain in terms of trying to bend the foot up themselves with dorsiflexion. And really, this is a combination of three things. It's really the tendon, which is the thickened tendon, or the tendinosis, which is the micro tear, so that's the thickening of the Achilles tendon. And then the bursa, that's the retrocalcaneal bursa, that's the space between the tendon and the calcaneus, and that can get inflamed. And then finally, this enlargement of this back of the calcaneus, which is what we call the Haglund's deformity. So there's a congenital or hereditary sort of predisposition to the anatomy of that bone, but that then can press on the tendon and create the inflammation, and in combination with the thickened tendon just causes this enlargement in the back of the heel. X-rays typically show or can show this calcification in the tendon. So if there's been a long-standing sort of degeneration or tendinosis, you'll see this calcification in the tendon itself. This sort of squarish back in terms of the calcaneus, that's sort of the Haglund's prominence, where it's harder to see in the sagittal plane. It's more the sort of posterior lateral projection, but is not uncommon with these type of insertional tendinosis. An MRI typically shows this, which is really the tendon. On a normal MRI should all have this sort of same thickness to the tendon, but here you see this really thickening of the tendon at its insertion. You can see some fluid or edema in terms of the calcaneus. You see this sort of longitudinal split, or a white signal in the tendon signifying some sort of longitudinal tear. Here is the non-insertional tendinosis, which is more uncommon, a little easier to treat than these insertional tendinosis. But in this case, you just see sort of the overall thickening of the Achilles tendon proximal to its insertion. So in terms of treating these, generally the initial treatment is to immobilize the foot. If the patient's limping or hobbling, difficulty getting around, then the walking boot can be helpful. Sometimes if it's not so bad, just the simple heel lift can elevate, take some pressure off the Achilles tendon. Then in combination of some stretching and some physical therapy can be helpful. But in the cases that just don't improve, then there are surgical ways to treat it. Generally, debriding the tendon, removing that degenerative, that calcium in the tendon itself, removing that prominence of the haglans, which is the calcaneal ostectomy. And if 50% of the tendon or more is involved, then we have to augment that typically with a tendon transfer. In this case, typically the flexor hallucis longus tendon. So that can be a good surgical way in terms of providing relief on these patients. The anterior tibialis tendon or anterior tibial tendon, that's the major tendon in terms of bending the foot up, allowing the foot to clear. So there's other tendons that are toe extensors that cross the ankle too, but the anterior tibialis tendon is really the major tendon that does that. So we can see an inflammation of the tendon, we can see a longitudinal tear or tendinosis, or even a complete rupture. In terms of just anatomy, it originates along the upper outer leg, it courses under the superior retinaculum, then the inferior retinaculum, and then attaches to the inner part of the foot. In terms of demographics, typically patients 60 to 80 years old can be associated with different systemic conditions, different inflammatory conditions, gout, diabetes, rheumatoid arthritis. These patients often do have sort of these prodromal symptoms that they'll have the pain or discomfort in the front of the ankle. It's chronic problem. Some get a steroid injection. The steroid can weaken the tendon, and then over time, just the repetitiveness of walking, the tendon just gives and ruptures. And typically, it's at the insertion spot. Sometimes that can be combined with a stumble where the foot bends down and just overcomes the degenerative tendon. So delay is not uncommon. So these patients at times can still have the ability to bend their foot up because of the toe extensors that we talked about. So sometimes it's not picked up initially, but they'll typically describe sort of a slapping gait. It's hard for the foot to sort of clear the ground. This might not happen until they're walking for 20 minutes or 30 minutes, so they just feel then they just don't have the stamina to repetitively lift the foot up. In terms of examining these patients, one of which is to try and get them to walk on their heels. They can't do that if the tendon's not intact. If you really have them try to put the toes down and then try to bend up, and you're eliminating the extensor tendons and relying on the tendon, and that's difficult if it's disrupted. But this is really a good way just to have them dorsiflect both sides. And here you see on the right ankle here, you see a good cord-like structure of the anterior tibial tendon on the right, and really not there on the left. In terms of treatment, very uncommon to just treat this non-operatively, maybe just a real low demand patient, but it typically is a deficit in terms of being able to walk and stand. Sometimes placing them in a brace, so some sort of plastic AFO brace, which essentially is a brace under the foot, under the calf, keeping the foot at 90 degrees. So that can help with that sort of stamina and that foot slapping. The surgical way is to try and get the function back in terms of lifting the foot. And usually this is in a degenerative situation, so it's a bad tendon. It's usually not able to bring the two tendons back together, and it's not good quality tendon. So usually we have to transfer a tendon to bridge that gap. Typically we use the extensor hallux longus. That's one of the two extensor tendons of the big toe. So essentially we're taking it here more distally along the big toe. We sew the extensor hallux longus stump to the extensor brevis, which is the second of the toe extensors, and then we essentially release it and then weave it back through with a course and then back into the bone. It can take the place of that ruptured tendon. So another major or another significant problem we see is problems with the posterior tibial tendon. So posterior tibial tendon essentially is responsible for holding up the arch of the foot, initiating the heel, coming off the ground, and walking. So we can see an inflammation, we can see a partial tear or even complete rupture, but most of these are longitudinal tears that then stretch out and then lead to a flattening of the foot. Typically, we do see this in patients who have flat feet to start, but this is something that develops over time, and some of the other terms for this are adult-acquired flat foot or posterior tibial tendon dysfunction, but both are an attempt to sort of try and describe the different stages along the spectrum. But initially, you'll see this sort of bogginess along the medial ankle, swelling along the sheath. So really the tendons come in here and coming along the back, just around the inner ankle. These patients will be swollen and tender right there. Again, their foot will look flatter often on that side compared to their other side. These patients will have pain going up and down stairs or trying to elevate and bring the heel off the ground. So posterior tibial muscle originates higher up along the leg and then really attaches along the inner part of the foot, primarily into the navicular, but then also to these cuneiforms planarly also. So in terms of the type of patient, this is usually more females than males, typical 50 to 60. If it's a younger patient, then think inflammatory condition. But the basic issue is that there's some tear of or degeneration of the tendon, which then can lead to a partial tear or a larger tear, which then leads to this flatness of the foot. So really there can be a spectrum from really a well-aligned foot where there's just some inflammation or minor pain to really a complete collapse of the foot. So here's an example of just a real significant collapse. Typically what happens is initially they'll have the pain on the inside part of the ankle along the tendon, but as this tendon stretches out, this calcaneus sort of slides out into what we call a valgus position, which then can cause the calcaneus to hit the fibula, and then they start to have this sort of lateral foot or lateral hindfoot pain once this swelling and this pain subsides along the inner part of the ankle. When the foot goes into that position, that allows that heel cord or that Achilles to become tighter as well. This is really just a diagram just to show the different parts of the deformity, but essentially this is a forefoot abduction where essentially this foot is where the tendon attaches, but this really allows this part of the foot to actually rotate or point outward. This is just really the collapse of the foot in terms of the arch, and again this is this valgus in terms of the calcaneus in terms of the position. So again, in terms of the physical exam, really the single heel rise test is really the best test, or one of the best tests in terms of assessing for this. So really having them stand up straight, support themselves with their hands on a table, and then with just the one foot that's involved, try to come straight up off their heel, and often they just can't do it because it's too painful, or it's just the tendon is stretched out and it's too weak and they're unable to do that. So that's a good test for that. In terms of the treatment, initially, and if there's not much deformity, then typically using a brace or a walking boot for some period of time in terms of just trying to bring down the inflammation. Sometimes some PT can help as well, the orthotics. But if it's really a significant deformity, then these are just going to be longer term problems. And in this case, the basic parts of the procedure are to bypass that tendon that's stretched out to perform what we call a flexor digitorum longus tendon transfer. So that's one of the two two tendons that bends the lesser toes down, and so essentially we're rerouting that and attaching it to the navicular bone. But in addition to that, because the foot now has changed its alignment, we have to address that, else the tendon transfer is just going to stretch out over time. So one part of that is this calcaneal osteotomy. So this is making a cut in the heel bone and then shifting that about a centimeter medially, which then realigns the back of the heel more underneath the leg. And then often some other parts of that have to be addressed in terms of the bone or the alignment, but those are the two basics. So moving ahead to the peroneal tendons, really the two peroneal tendons, muscles that originate along the lateral leg. The peroneal brevis attaches to the base of the fifth metatarsal. The peroneus longus travels behind the brevis and attaches underneath the foot. It's the base of the first metatarsal. This is an axial view or view looking at the two tendons, and essentially they run in this groove behind the fibula. It's constrained by this peroneal retinaculum, which essentially is a ligament that keeps these two tendons in place and prevents them from subluxing or dislocating out. Here's just a diagram in terms of the bony anatomy. The peroneal tubercle is sort of the divider here in the outer part of the foot. The brevis travels above, the longus below, but the brevis travels, attaches to the base of the fifth. The longus comes in just underneath and then makes this turn in what's called the cuboid tunnel, so the cuboid bone, and then travels and attaches really underneath the first metatarsal over here. In about 15% of people, they have what's called an os peroneum. That's a bone or calcification in the peroneus longus right here in the cuboid tunnel, and one can have problems associated with that. So in terms of types of disorders we see, typically a longitudinal tear that can be a partial tear or through and through tear. We can see a dislocation or subluxation. This is typically sort of when the foot comes up and out, such as a skier who lands and the tip comes up, that forces those tendons out against the retinaculum. The painful os peroneum syndrome is really a combination of a few of these things, or can be one of these things that can be a fracture of the os peroneum, can be a partial tear of the longus at the os peroneum, or that they have some pain or enlargement of the peroneal tubercle. So back to some of the anatomy in terms of just the tear. The two tendons again lie in this groove. It's thought that the longus pressing on the brevis then causes this sort of flatten, rub against this tip of the fibula, and then this can become a partial tear, even a complete through and through tear, and so developing something like this. So this is really sort of the common area right behind the fibula. We're calling this a type 1. But these tendons, these issues can be associated with patients who have an ankle instability, that the ligaments have stretched out and they have chronic sprains. The peroneal tendons are important in terms of that side-to-side stability of the ankle. So on uneven surfaces or terrain, they're working to stabilize the foot so it doesn't turn over. And so those type of activities can cause these type of problems. Patients who have a high arched foot put more stress and strain on the muscle and the tendon. Those are the types of associated injuries we see. This is the subluxation or the dislocation. So this is really the foot being bent up and out, and you can see where the tendon is behind the fibula here, and then it just sort of sublux, so it gets pushed over onto the side of the fibula. So this is not such a common injury, but it does occur. So in terms of treatment, usually if these are more mild, we can treat them in a boot or a brace initially, try to decrease the inflammation, sometimes in physical therapy. If it's a more extensive tear, then those don't get better. And if it's sort of a simple partial tear, we can repair, essentially tubularize the tendon. If it's more of a significant tear, then we have to actually bypass, and this is the foot here, this is the upper leg, but essentially what we've done is transfer and tie the brevis here to the longus underneath and sort of bypass the area of tendon tear. So sometimes it's just not repairable. In terms of the dislocation, this is again that photo in terms of the tendon coming up, but really what we see here is that this fracture right here. So in some cases, instead of that retinacular ligament tearing, it can really just sort of pull off this piece of bone at its attachment and allow those two tendons really just to slide over. So this type of fracture really is a pathognomonic for peroneal dislocation, which is separate from this sort of avulsion fracture that you see at the tip of the fibula that we see in the ankle sprains. In terms of the peroneal reductions, so these really don't respond non-surgically. So once this ligament has torn or this bone has chipped off, then the tendon is just going to slide along the outer ankle. So here's this case of the tendon. That's the foot, that's the upper leg, but essentially just on the outer lateral side of the fibula. So some of these patients have what we call a shallow groove, that there's not a deep groove for the tendon. So there's ways to sort of osteotomize or deepen that groove in addition to repairing the ligament to keep those tendons in place. So on to some arthritic conditions of the foot. Almost always arthritis in terms of the ankle is a post-traumatic, almost always due to an ankle fracture. These patients typically have pain, stiffness of the joint. Again, it's important to get the weight-bearing view in terms of the X-ray to see the alignment. So in terms of this X-ray, you sort of see the tilt and the difference in space. This is a typical sort of patient who's had this sort of chronic ankle instability, that these ligaments have stretched out, and he's had these repeated sprains and has really sort of worn down that inner or medial ankle joint. So traditionally, or in terms of the types of ways to treat it, the bracing can sometimes be helpful to trying to mobilize the joint as much as possible, but there's still that component of just putting weight on the foot in terms of causing pain. Sometimes a cortisone injection can offer some short-term relief. Different shoe wear, orthopedic walker type shoe, one that has a good cushion support, a rocker sole shoe really has a sort of rounded area underneath the middle part of the shoe, allows one to sort of propel through the foot or the ankle, minimizing how much stress has to be put on the joint. So that can be helpful, but traditionally the surgical way of treating this was a fusion, so essentially fusing the tibia to the talus. There's different technical ways to do that, but that can have certainly a good outcome. It holds up over time. Obviously, one loses the motion of the ankle joint permanently. It can lead to wear and tear of the adjacent joints. So alternative is an ankle replacement, and so there's been some good advances over the last 15 years or so in terms of type of implants and development and technique in terms of the things we've learned. So still not the same as the total knee or the total hip, but our experience really is probably about a 90-95% survival of the implant at 10 years and about 50 to 60% at 15 years. So these patients can have a good outcome and maintain their flexibility given it's the right patient. There are components in terms of the alignment of the foot underneath the replacement and making sure that's balanced and that's able to allow the forces across the replacement to hold up after time. So if the foot's not balanced underneath the ankle, then those will fail. So other types of arthritis in terms of the foot, one of the common is this midfoot arthritis. So these patients typically come in feeling that there's a pain along the top of the foot, might look a little swollen, feel there's these bumps or bone spurs on the top, sometimes can have difficulty in terms of different shoe wear, but almost always this is the midfoot arthritis. So these arches support the arch of the foot. So really, in terms of treating this, the more support underneath the arch, the less stress you're putting in terms of those joints. So typically an orthotic, some sort of orthopedic walking shoe, the rocker sole shoe can be helpful for this too. And if those really don't work, then cortisone injection, but again, usually just a short-term solution. And the surgical way is really to fuse these joints, which is and can be extended recovery, but can be helpful if the pain is pretty debilitating. In terms of the big toe, or the arthritis of the big toe is really what we call Hallux Rigidus, so a stiff first toe. It's really not a bunion. People come in, and the patients come in and think the bump is the bunion, but the bump on the inside is the bunion. The bump on the top is really the bone spurs. So patients will feel that they have difficulty in shoe wear, sometimes difficulty in terms of the heel chew because they don't have flexibility in terms of bending the toe up. So typically orthotic, rocker sole shoe again. In terms of surgery, we grade these type 1, 2, or 3. Type 1 or 2 are sort of the mild or moderate, where there's still some cartilage left, but still some motion. But chylectomy, which is essentially removing the bone spurs along the top part of the joint, that can help in terms of decreasing the pain related to the bone, hitting the bone when the toe is bent up, and it also can increase the flexibility in terms of the joint. So that is helpful in the lesser types of arthritis and more severe arthritis. Fusion has really been sort of the traditional way of treating this. So essentially fusing that joint at typically a 15 or 20 degree angle to allow the toe to clear and roll through the foot. But that can be a good, successful treatment in terms of the pain. Holds up well over time. More recently, the Cartiva implant, which has been available in the United States over the last 2 years, been available in Canada and Europe for the last 8 to 10 years with some good results. But traditionally in the big toe joint, implants have not had a good longer-term success, but this has had some good success so far. So essentially that's trying to maintain the motion of the joint. So you're essentially putting this spacer in the joint to take some of the pressure off of the bone rubbing on bone, and again, to preserve motion versus fusion. And knowing that if this fails, then one always has the fusion to go back to as a fallback. In terms of some of the fractures that we see in the foot and ankle, obviously most are some fall or twist or such, typically can't bear weight, they're displaced, and generally have to fix. So here's sort of a subtle transverse horizontal fracture of the distal fibula. So this is something that can be treated non-surgically, typically in a walking boot and bearing weight. This is more of an oblique or spiral fracture of the distal fibula. You see the space or increased space here too. So really this talus is shifted out with the displacement of the fibula, so that does need to be treated in terms of reducing and stabilizing with the plate to realign the alignment of the joint. And then this is what we call a trimalleolar fracture. That's a medial malleolus, lateral malleolus, and then this in the back, posterior malleolus. So that's obviously a grossly unstable fracture that needs fixed. In terms of the foot, most fractures of the foot generally can be treated non-surgically in a walking boot, but typically you see the swelling and the bruising. If there's significant displacement, or if there's some, depending on the location of the fracture, then do need to be fixed. But here's a second metatarsal fracture, so minimally displaced. If this is too displaced in sort of the sagittal plane or the side view, that it's elevated too much, then fixing this. But most metatarsals, we can accept some displacement. So here's this distal fifth metatarsal fracture. There's a good amount of motion at the tarsometatarsal joint here, so we can accept more displacement of a fracture of the fifth metatarsal than maybe the second or the first. But that could and was treated in the boot. The fractures of the base of the fifth metatarsal really depend on the zone or the location in well they heal, and that's really predicated on the bone supply. So these zone 1s are really at the base. This is what we call an avulsion fracture. So here's a small one here, a little bit larger here, but all of these heal and typically just a cam boot for 5 or 6 weeks. The zone 2 is what we call a Jones fracture. So this is really at the junction of the metaphysis and the diaphysis of the fifth metatarsal, and really has poor blood supply. And so these usually do not heal well without surgery. These zone 3s are either further down, and they're really more chronic stress fracture of the fifth metatarsal. So here's just another example of the Jones fracture. So again, studies have shown about a 75% chance of these healing with not putting weight on the foot for 6 to 8 weeks. So that's a long period of time not to put weight with 25% chance it doesn't heal. So the surgical way of treating these and allowing them to bear weight almost 4 or 5 days after the surgery is placing an intramedullary screw crossing the fracture to stabilize. The Lisfranc injury is something that refers to this ligament here, the medial cuneiform in the base of the second. So this ligament, named after Napoleon's surgeon, who really described more of a midfoot amputation, but had his name associated with the ligament, but essentially can be a tear or disruption of that ligament. This joint right here really is the keystone of the arch of the foot. So if this is not aligned, it really allows this whole foot to collapse and shift. So this can be a very subtle injury and just involve the ligament, or it can involve the base or small fractures at the base of these bones, and can also then incorporate the other joints. So helpful to get a standing x-ray in these to really put the weight on the foot to see the alignment in terms of the foot. These are subtle, so these are standing x-rays. So here you sort of see the space here, here, and then compare it to here. So certainly a difference on the right. Here's another example of that space compared to the other side. So it's wide and it's subtle, but this doesn't imply that there's some separation of that space. CAT scans can be helpful. We see these small small avulsion fractures where the ligaments attaches, which is another sign of an injury at that spot. This is a motocross competitor who just really fell, landed, really his foot turned over in a plantar flex position. That's sort of the general mechanism, but you can see the widening of the space here. This really extended through here. He had a fracture of his navicular here. Dislocated his second metatarsal too. But essentially, mostly a ligamentous injury in terms of the Lisfranc area, so really putting screws to stabilize, protect it for a good 8 weeks after the surgery, fix a smaller fracture here with the smaller screws. In terms of just the toe fractures, really those are almost always non-surgical, different patterns, but usually are a spiral, which treated buddy taping and post-op shoe. So rarely these have to be reduced or any surgical intervention. Other types of fractures, so acute fractures, obviously with the specific fracture of specific turn or twist. Stress fractures are quite common as well in the foot and ankle. So we recently published this chapter in terms of stress fractures in the ankle and the hindfoot in athletes. But generally, you're looking or you're seeing swelling or pain without trauma. Most often, some change in exercise regimen or workouts. Difference in terms of shoe wear, a new shoe or an old shoe that just has worn down too much. One most common is the metatarsal, but in terms of going through some of these can be very subtle, and the x-rays can be negative initially. So here's the distal tibia. You can sort of see this whitening or sclerosis along the distal tibia. You can sort of see that right here on the side view. So that's subtle, but can take a few weeks to show up, but that's a fracture of the distal tibia. This is the fibula. This is maybe even more subtle, but there is something there. But these typically in runners, the distal fibula fracture are usually pretty tender and sore right on that spot. So really, a lot of this is a clinical diagnosis. Typically treat them in a boot initially. The medial malleolus stress fracture can be subtle as well in terms of x-ray. This is a CAT scan. stress fracture of the calcaneus, so the line's right here. So again, often the x-rays are negative initially, but in terms of this type of injury, it'll be pretty sore on both sides of the calcaneus. You place them in a boot, you see them back in 2 weeks, and then see the x-ray, and then you start to see some bone forming in terms of the x-ray. So that's the stress fracture, the metatarsal. Navicular stress fracture, so this is sort of at the junction of the 2/3 medial and 1/3 lateral with some diminished blood supply. Typically it's a fracture that goes from the top of the bone down planarly, but these have very hard or difficult to heal non-surgically, so typically it's screw fixation in terms of fixing that. And then finally, here's the stress fracture of the 5th metatarsal, so again, further down. So that's your avulsion, that's sort of your Jones fracture there, and this is more distal to that. So this type of fracture generally needs surgical fixation as well, usually in a patient with a high arched foot or a cavus foot that loads that part of the foot more. And then just to sort of wrap up, but just to sort of go through some soft tissue or other common type of foot conditions that we see, plantar fasciitis. Very common. Typically, it's this pain along the undersurface of the heel. Patients will feel it with the first few steps in the morning, after sitting for a period of time and then standing, but also just in general in terms of the more they're on their foot. Usually no specific twist or turn. People with a higher arched foot tend to get this, but really it's not an inflammation. The name fasciitis implies an inflammation, but it's really a tear or partial tear of this attachment, this medial or inner attachment of that band of tissue to the heel. This band of tissue, the plantar fascia, really is part of the arch of the foot, so it originates on the heel, but really attaches all the way to the toe. So when you bend the toes up, that tightness, that's the plantar fascia. But this is so in terms of treating it, the general things are a stretching program. So this is a plantar fascia stretch. So really to bend the toes up, hold that for a good 15 seconds, 3 or 4 of those, 3 or 4 times a day. And then this calf of the calf stretch, where it's really the push up against the wall. The night splint is a way of stretching plantar fascia in the Achilles while one sleep. And then some sort of orthotic or gel cup or such in terms of the shoe to diminish the shock in terms of the heel. So it's not a bone spur. About 40 or 50% of people have bone spurs here that have shown no correlation to heel pain. We really don't recommend a cortisone injection. Cortisone can weaken that fascia even further, can lead to a tear or a greater tear, can lead to some fatty atrophy underneath the heel, and that can create greater problems. Bunion means a bump, but really is the angle between the great toe and the rest of the foot. So most patients think it's an extra bone that just want to shave it off, but it's not that simple. It's really the angle, and so here's just a x-ray, so you sort of see that angle here. Really what the issue here is that there's this instability or laxity of this joint right here, the tarsometatarsal joint, which allows this bone to, instead of being parallel to the second, to shift out, and so that creates the prominence of the bone. And there's different sort of deformities. Here's a pretty significant deformity, but then can lead to the first toe coming under the second toe and other lesser toe deformities. She also has some arthritis here as well. So obviously, wider the shoe, the less of a heel. The heel tight shoe obviously pushes the toe over in the shoe. Different ways of treating this, primarily osteotomy or fusion. Osteotomy is really different ways to cut the bone to correct this angle so that the first is in parallel with the second. For lesser deformities and no significant laxity of this joint, then we can do the osteotomy. In this case, with no oblique osteotomy. If it's really more deformity, or there's a significant instability of this joint, which about 50% of the time there is, then really one needs to correct the angle at that joint by fusing the joint, which is a way of preventing any recurrence and stabilizing the foot. So here's just an example of the 2 screws in terms of fixing it. The hammer toes, claw toes, really just deformities of the lesser toe joints. The hammer toe is the proximal interphalangeal joint. That's the PIP joint. The MTB joint is where the toe corrects to the foot, and that is more of an extension deformity. So typically just a wider shoe, toe box, surgical ways, or in terms of the hammer toe, excising some of the bones, straightening the toe and pinning it. So different types of different shields and straps. The neuroma is really this pain under the ball of the foot. Patients will feel it more in a constricted shoe. At times they'll feel it extends into the toes. It's more common in the third space than the second space, but essentially pinching in that spot can replicate the pain. Orthotic can help. Sometimes a cortisone injection can help, but again, usually shorter term and surgical way is to excise the nerve itself. Capsulitis is really referring to this metatarsal phalangeal joint, which is really the claw toe joint. This can be a spectrum of deformity and pain, but can start as just a normal appearing looking toe, can sometimes be misdiagnosed as just a neuroma, but what we call the Lockman, which is really trying to stabilize the toe and really just sort of bend it up in terms of just stressing it, and that is quite painful if that joint's inflamed. Often as this goes on, this plantar plate, which is a ligament underneath the metatarsal phalangeal joint, then stretches out, allows the whole toe to come up and then come over, in some cases, over the first toe. So the surgical way of treating this is usually some sort of soft tissue release, usually an osteotomy of the metatarsal, where we do some oblique osteotomy, shorten it a millimeter or two, and then hold it with 2 small screws to keep the toe in place. So the taping is just can be an effective way in terms of stabilizing a toe or just treating it symptomatically in the short term. And then finally, metatarsalgia, just sort of a broad term for pain underneath the ball of the foot. Can be a result of what we just discussed, but can also be the anatomy or structure of the foot, and usually the metatarsal pads or some sort of unloading of that part of the foot can be helpful. So I think that's it. So that's all I know. So we can take some questions now.
And as a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not respond to all questions submitted. And now back to Dr. Hubbard for Q&A.
Sure. So, question regarding had the surgery without Cartiva, but with biocartilage. Trimmed off the flap of the detached cartilage and filled it with the bio. So yeah, so I mean, in terms of if there's a specific focal area of cartilage that's been lost in terms of the bone, so we call those osteochondral lesions that can happen in the ankle or the big toe joint. But biocartilage is an allograft that can be used, yes, to trim off the cartilage flap, to drill a small hole or two at the base of that, and then graft it with the biocartilage. And so yes, we've had some good success with that. How long would you give a peroneal brevis tendonitis to heal before doing surgery? So the tendonitis, I'd say, almost always is because there's some injury to the tendon, either a strain or a small tear. Sometimes we don't even see that in terms of an MRI. I think, a boot or a brace for 3-4 weeks, something like that, and then some PT. But the peroneal tendon disorders in active athletic people usually are problematic. So I think it certainly warrants some period of mobilization and PT, whether that's a month or 2 or 3. But if that doesn't get better or returns when one returns to the level of activity, then I would recommend surgery for. Let's see. Can you speak about the prevalence of accessory navicular in the posterior tibialis tendon injuries? Yeah, so accessory navicular in about 15% of people. It's an extra bone or an accessory bone inside the posterior tibial tendon at its insertion. There's different types based on the size, but it is a component in flat foot and posterior tibial tendon injuries. Those can be problematic. Typically, people don't have pain until they have a specific twist or turn, and then that sort of aggravates that synchondrosis, or that connection between the accessory bone and the main navicular. But usually in orthotic, sometimes initially, if one has a specific injury and it's recognized early on, a cast or a boot to really immobilize it to try and get some sort of fibrous connection back can be helpful. But typically those are trying to manage with it. And then the surgical way is to excise that accessory navicular and repair the tendon, and that can be successful, but it is something that one really does have to protect the tendon for a good period of time after the surgery. How do you clinically diagnose the PTT tendon rupture? The rupture itself usually is really just a complete flat foot. So you really see a real significant flatness to the foot. So it can be a spectrum where the foot slowly gets flatter and flatter, but then the tendon ruptures and it's just the cascade, and then so it's really a significant flat foot. Those patients cannot single heel rise in terms of trying to bring the heel off the ground. So for a specific population for that group, usually an older group, so 60 to 80 or so. So the younger patient can get the tendinitis, maybe a strain. Usually those can respond to PT, a good orthotic, but the older patient where it's a more degenerative tendon, and especially once it starts to stretch out and the foot flattens, then that's sort of a point that can be harder to treat non-surgically. What are the options for treating disabling distraction of a bipartite great toe sesamoid following cast boot use for a fifth metatarsal base fracture? So the sesamoids are two bones in the flexor hallucis brevis tendon, which is one of the two tendons that bends the big toe down. So that's really under the ball of the foot, under the great toe, and one can have a spectrum of injuries. Sometimes that's a fracture, sometimes it's a bipartite. Bipartite means it was just formed in two pieces. That maybe it's 10 or 20% that we see some multi-partite sort of anatomy, but in terms of how to treat that, usually in orthotics, so there are ways to unload and depression underneath that specific spot. But then there's some limitations depending on what sort of activity, and if it's impact or running or such, sometimes those don't work so well. But for the sesamoid, the surgical way of treating it is excising it. There's two, the medial and the lateral. The medial, just typically we can go through a medial incision. The lateral, we have to go underneath the foot, so just a longer recovery in terms of taking out. But certainly you want to try orthotics and trying to really unload that part of the foot, and at some point, if it doesn't get better, the surgical ways to treat it. Okay, I think that looks like it for questions.
All right, and with that, on behalf of Morristown Medical Center Orthopedic Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this brief CME evaluation summary form to receive credit for attending the webinar and providing feedback of the webinar. This concludes today's program. Thank you and have a great day.